Okay, so this is just for the protocol. We're going to go through all the details of the protocol. Many questions are going to raise in your mind. Please feel free to interrupt whenever you want, and we have plenty of time to discuss that. So very important, the inclusion criteria from the trial. You can see that the inclusion criteria are quite broad. So we want to include as many women, as many female as we can. So we have the regular definition of aortic stenosis. The basis, we want to include only symptomatic aortic stenosis patients. Only symptomatic aortic stenosis ladies. So these are the standard definition with the jet velocity above 4 meters per second or a mean gradient above 40, with a valve area below 1 or indexed below 0.6 centimeters square per meter square. Or, and this is quite new, we're going to include the low gradient severe AS, and this provides all the another interest to the trial, because most of the time this subset of patients was excluded from the randomized trial. So we allowed the inclusion of low gradient severe AS as defined as follows. And I had that discussion with David Messika-Zetoun about the calcium score. Calcium score is required to make sure that the patient has a significant aortic stenosis with a low gradient, more than 1,200 Hounsfield unit for the ladies. So it tells us that we need to acquire a CT scan for the patient at baseline, even for the patients that are theoretically surgical candidates, just to make sure that we have a proper assessment, and we're going to detect and include this cluster of low gradient severe AS patients. So we have clear definitions, and this is new. This type of patient is going to be included. So the patient has to be symptomatic, at least in NYHA class 2. The other symptoms are allowed for sure. And if the patient is not really symptomatic, we require an exercise, a test that demonstrates a limited exercise capacity, or an abnormal rise distribution of the blood pressure, or even arrhythmia during effort. So assessment of the patient at baseline is really important. If you have a patient who had a previous TE transthoracic echo, you think that it's a good candidate, just make sure that all the criteria are met, particularly if you have a low gradient AS and or a patient that is not highly symptomatic. Make sure that you have everything, bring back the patient, repeat the testing, CT scan or exercise testing if required. So the exclusion criteria, we have a quite broad list of exclusion criteria. You're going to get all these items, but these are quite logical ones. We want to make sure that we don't integrate factors that are going to generate some noise when it will be time to interpret the outcomes. So we want to make sure that the patient has a suitable anatomy for the available for the study device. So that tells us that CT scan, once again, is mandatory for the screening process. Every patient needs a CT scan, and we have to make sure that the annulus is in the range of a 20, 23, 26, 26 S3 or S3 Ultra, or 29 S3. The 29 will be the S3. There is no 29 S3 Ultra. So the vessels have to be compatible with adequate transfemoral access for the introducer, whether it be the 14 French or the 16 French E-sheath. Acute myocardial infarction within 30 days. Bicuspid or unicuspid valves are not the focus of the trial. Maybe we will run, if you want, if somebody has the idea in the future, we will need a dedicated trial on bicuspid patients, but this is another topic. So we exclude bicuspid patients from this trial. Severe aortic regurgitation is excluded, but most of the time, if you have an extremely calcified valve that is regurgitant, based on the echo analysis, we may accept the patient or not. But if you have pure severe aortic regurgitation, the patient is excluded from the trial. Any concomitant severe valve disease that requires an intervention will be excluded. We don't want to get two surgical valve procedures at the same time, because it's not the focus of the trial. Any valve prosthetic substitute in any position If the patient has a complex coronary artery disease, we're going to exclude the patient. So we have to make sure that the syntax score is below 33, that we don't have any unprotected left main, and that the heart team agrees that syntax score below 32, no left main, we can achieve a good PCI for the patient just before or during the procedure. So coronary angiogram is required for eligibility of the patients, and we will make sure that the syntax score remains below 32 and we don't have any unprotected left main. Once again, to be sure that we focus on the valve, on the woman, and we don't integrate over bias to the trial. So if we have a peripheral disease, particularly at the level of the carotid of the vertebral arteries that may promote some stroke and generate some stroke, the patients are going to be excluded. Blood disorders, these are the regular definitions, you know that. In unstable patients, patients with mechanical ventilation, mechanical support are going to be excluded. If you have highly severe septal hypertrophy with an obstructive cardiomyopathy, the patients are not going to be included in the trial. LVEF, and this is quite important because we may see this low flow, low gradient AS with depressed ejection fraction. The threshold is 30%. So the LVEF has to be above 30% to be accepted in the trial. Any evidence of thrombus, intracardiac mass, vegetation, endocarditis, for sure the patients are going to be excluded. It makes sense. If the patient has any contraindication to antiplatelet or antithrombotic treatment is going to be excluded. And for stroke, we require that the occurrence is above 90 days before randomization. So these are the regular exclusion criteria that we all know and we see in all the trials, registries that we've run: severe renal failure and active endocarditis, FEV1 below 50% for the lung function, pulmonary hypertension, and this is something that is new. We don't have a dedicated number, but we exclude the patient with a pulmonary arterial systolic pressure that is above 2/3 of the arterial systolic pressure. Cirrhosis or active liver disease are going to be excluded. Peripheral disease at the level of the abdominal aorta and so on are going to be excluded. Patients with hostile chest are going to be excluded. This is for the surgical arm. So these are not regular TAMV candidates. Ideally, what we expect is to enroll more of low-risk patients in this population. So the patients need to be suitable candidates for any conventional surgery. Really obese patients, more than 50 kilograms per meter square of BMI. The patients in poor conditions with a life expectancy below 2 years are going to be excluded. So this is a subjective estimation, but you have to honestly assess that just to make sure that the patient is going to live at least 1 year and we're going to have an outcome at 1 year because the primary endpoint is at 1 year. So these are not regular TAVI candidates. If it is an inoperable patient, high-risk patient, maybe this is not the right type of patient to include in this trial. Okay, and pregnancy, normally it shouldn't be an issue in our population. But I'm saying that, but I've already been contacted by a patient, a lady who is 44 years old, just to be enrolled in the trial, and Adeline can assess that. And this is something that we may face, so this is one of the exclusion criteria. Okay, so overall, as we said, we're gonna include 440 females here within the trial. You make sure that the patient fulfills the inclusion and the exclusion criteria, so this is your duty. We're going to assess that during the monitoring, but we want to avoid any deviation to the study protocol. So just pay attention to the inclusion-exclusion criteria when you select a patient, when you screen a patient, just to make sure that we have everything. So transthoracic echo with recorded loops is mandatory. CT scan is mandatory. If you have a low flow, low gradient AS patient or an asymptomatic AS patient, go for a stress testing before submitting your patient. So you have to collect all this testing before sending your screening slides to the steering committee. Once you get that, you have to consent the patient first, and then you send the images, the slide deck that we're going to discuss in the second part of the day, the screening slides to the steering committee, and within 2 days, 48 hours, you will get an answer whether or not your patients can be randomized. So within 2 days. So this is going to be a fast review process just to make sure that everybody can treat his patient in a very flexible way. So it's going to be a one-to-one randomization between TAVI and surgery, TAVI, PCI, surgery, CABG, syntax score below 32, no unprotected left main, but one-to-one randomization. And then after the procedure, we will have a post-procedure assessment 48 to 72 hours. Assessment at discharge. These two can be combined based on the discharge day of the patient. So this is something that we can simplify. If the patient is discharged at 2 or 3 days, you can combine both. So then we will have a 30 days follow-up, 6 months follow-up, and the primary endpoint will be at 1 year. And we're gonna describe the primary endpoint afterwards. So this is a sequence that is important to keep in mind. So you have a patient that is eligible. You need to make sure that the patient is really eligible, consent the patient. You send the patient for screening eligibility by the steering committee. You get the answer within 2 days, 48 hours. You can randomize the patients, but from the consent to the treatment, the window is 30 days. So you have 30 days to consent and treat your patients. So this is very important, otherwise we're going to integrate study protocol deviations. So 30 days is a quite large window, and you will have at least 28 days, because you send you screen the patient, you consent the patient, you send the images, we accept the patient, you can randomize, and then you have, after these 2 days period, you still have 28 days to treat the patient. So it's a quite comfortable window for doing that. Then, as I said, the first assessment post-procedure at 2 to 3 days, a discharge, some safety endpoints. At 30 days, plus or minus 10 days, over 8 points are going to be assessed. At 6 months, it's going to be it could be a phone call. If you want to bring back the patients for assessment, you can do so, but a phone call is allowed. And then the primary endpoint, the most important, would be at 1 year. So what is that primary endpoint? It's based on the partner-free definition, and it combines exactly the same items as partner-free. And just to remind you that every single item was significant in that trial. So this is not a combination just to make sure that we artificially promote TAVI or so on. This is based on the available outcomes in the literature. The so-called all-cause mortality, all stroke, disabling and non-disabling, and rehospitalization, valve-related, procedure-related of worsening of congestive heart failure. So this is the composite primary endpoint that is going to be assessed at 1 year. So for the sample size calculation, everything was based on the partner-free trial, and we end up by estimating the event rate of 16% within the SAVR, the surgical arm, and 8% within the TAVI arm. If you remember in the partner, it was about 8.1 to 8.5% in male and female. And so overall, we estimated that 440 patients could be enough, accounting for withdrawals and so on, loss of follow-ups, to make sure that we have the appropriate power to identify a difference between both treatment arms. Everything is based, all the definitions are based on the VARC2 consensus document that you know. For those who are not really familiar with that, this is the type of definition that we use for every single registry or randomized trial that has been run since 2013, and the first descriptions of these definitions. We had previously the VARC1, but VARC2 is the set of definitions that we use in daily practice now. So just to illustrate that disabling stroke is going to be part of one of the endpoints, as will be non-disabling stroke, but it's not a matter of feeling, saying, oh, the patient has a disabling or a non-disabling stroke. This is based on a true definition, on a true assessment. And the most important thing is to do a modified ranking score from baseline and then post-procedure and then at 90 days to make sure that the patient didn't experience stroke, or if the patient has stroke, this is a non-disabling or a disabling stroke. So we have a clear definition on that. And this is extremely important. So that MRS should be assessed by a qualified person according to a certification process. So you may already have in your center somebody who is dedicated to the MRS assessment with a valid certificate. If it's not the case, you will need to identify a couple of persons. It's not necessarily a neurologist in your department, but it could be a surgeon, it could be an interventional cardiology, a study nurse, a research coordinator from another type. It doesn't matter, but that person needs to be certified. So you will need to, once you go back home, to try to understand if you already have somebody like that who is certified. If it's not the case, it's an online certification, so don't be afraid. It's not something that is not achievable. There is a dedicated website. You go there, you follow the training, 1 hour training, and then you get your certificate that is valid something like two years or something like that. So it's not something that is not achievable. But this is mandatory just to make sure that we collect the appropriate outcomes, we all talk the same language, and we do the things in the right way. It's not a registry, it's a randomized trial. It's something that is really important for the patients, really important for us as a medical community to prove that we can achieve a very good randomized trial. So you need to make sure that you have this type of persons who is going to do the MRS assessment in your center. Do we have a certificate? If not, go. We will send the links. You go online, you do your certification process, and then you are set for the whole duration of the study. And maybe something that is quite important is just to make sure that the same persons assess the patients from baseline and then follow up, just to make sure that you capture the small, the subtle changes in the status of the patient. Okay, so just so the MRS, you have from 0 to 6. The higher the score is, the more disabling is the stroke. 6 being death of the patient. So we have a really specific assessment of the patient. It doesn't take a lot of time, but we have to go through that process, and it has to be done by certified people in a dedicated center. So apart from the primary endpoint, we will assess some efficacy and safety endpoints, the length of hospitalization after the index procedure. As Nikolaos and other surgical colleagues have discussed, the occurrence of moderate or moderate to severe patient prosthesis mismatch at 1 month, new onset atrial fibrillation at 1 month and 1 year, because this is something we need to understand, because it may impact the treatment of the patients in the future. Maybe women have more susceptibility to develop atrial fibrillation post-TAVI or surgery. We don't really know that, and we're going to see that in that trial. Major vascular complication at 30 days and 1 year, because Hélène just pictured that in the previous slides. It seems that we have more major vascular complications in women after TAVI than in male. We're going to see if with these new platforms it's still the case. We all have experience. It's a mature procedure in Europe. We're going to see if we can achieve low rates of vascular complications in that female population. Bleeding is really an issue with ladies, particularly post-surgery. So we're going to see if life-threatening, disabling, major bleeding at 30 days and 1 year is an issue, is still an issue in that female-focused randomized trial. Acute myocardial infarction, 30 days and 1 year, and acute kidney injury, stage 2 to 3, according to the Aiken classification. It's the one that is used, that is promoted by the VARC2 consensus. So it's a specific assessment. And this is, we're not going to go through the details, but just to tell you that it's a combination of the rise, the difference, the progression of the creatine level, the decrease of the urine output, and so on. And then we can classify the patient between stage 1, 2, 3. And we're going to focus on the most aggressive complications, stage 2 and 3 acute kidney injury for our patients. Okay, so as usual, just to illustrate that we're going to collect every kind of the most frequent complications in this population. And if you have in the future ideas about studies you want to run after the publication of the primary endpoint, you can start to think about this, and we can discuss that during the steering committee meetings to see how we can anticipate the things for the future. So a new permanent pacemaker will be frequency will be assessed at 30 days and 1 year. The functional status of the patient, the hemodynamic valve performance for sure, the cognitive function, and I do believe that this is something that is quite important because it may highlight a real difference between surgery and TAVI in terms of cognitive decline, because we may treat in the future a low risk, lower and younger patients, and we have to make sure that we don't damage the brain for this patient. If you want, we may discuss the use of cerebral protection devices. This is something that is quite open, and we, if you want, we can discuss that afterwards. And frailty is going to be assessed at 30 days and 1 year. So from the cognitive function, once again, the identified person in charge of exploring the brain disorders in the patient will need to go through all these 3 assessments. So it's a quite demanding, but it doesn't require such a long time if you get used to that. So that's why it should be the same person. First, running these tests, and second, exploring the patient from baseline to the study timelines. So the MMSE, we're not going to use the regular version in which you make the patient draw and so on, count backwards and so on, because it's too lengthy. We're going to use the MMSE2 that it only takes 5 minutes in the brief version to assess. So, but this is going to be compared from baseline to the study timelines. So it's going to be important that you get used to that you know how to run that within 5 minutes, and you repeat that in the same way. The NIHSS, you all know that. This is very simple to use. You have a 15 item scale, and most of the time it takes 5 to 10 minutes to achieve. The MRS, we already talked about that, so it's going to be a combination based on the timeline, whether it be at baseline, 30 days, 1 year. The combination is going to be variable, but you will have to become familiar with these 3 testings. Frailty is a little bit more challenging. It has to be assessed at baseline. We have the blood assessment with the albumin, for example, and we have these regular items. Maybe you are used to that, the CATS score for the independence of the patient in daily activities, the grip strength, the 5 meter walk time, the albumin level. So this will be combined to assess the frailty of the patient. But as we aim to include mostly low-risk patients, we shouldn't see so many frail patients, but we will see. Frailty is not an exclusion criteria. And then at last, quality of life. Quality of life. We try to take the same items that were explored in the randomized trial, in the partner 3 trial, and even the low-risk trial. And this is the Kansas City Quality of Life questionnaire. It's a little bit lengthy, but we will have to do that, and the SF12. And this will be assessed at 30 days and 1 year. So not at every single visit, but we will have to do so. And this, once again, can be assessed by not the surgeon or the interventional cardiologist, but you have to identify a dedicated person that is going to run the frailty tests and the quality of life assessment. So it's just a matter of organization, determining who is going to do what at which timeline, and just to make sure that you get the things in the proper way. One single person cannot do everything, so you need to be organized as a team in your center. So we now come to more busy slides, but it's a kind of summary of what we're going to assess from baseline to 1 year. So you see at baseline the functional status of the patient, physical assessment, and as usual, the neurological assessment at baseline, the MMSE2, all 3 testings will be assessed at baseline and okay. The risk scores as usual. At the time of procedure, but most importantly post-procedure and or at discharge, you will need to reassess the cognitive, the neurological and cognitive function of the patient by these testings. Laboratory investigations. Pregnancy test, okay, we'll see. Depends on the patient, but these are standard of care. Maybe the albumin is not really, albumin and bilirubin are not standard of care in your practice. Just make sure that for the Rheia trial, you create a protocol in which every single patient gets all of these testings at baseline, just to avoid missing data and bias within the study protocol. For the non-invasive test, invasive test, the ECG, a transthoracic echo, the pulmonary function, and also the quality of life questionnaire. What is going to be repeated is the ECG and the echo at discharge, at 2 to 3 days and or at discharge. But once again, these both timelines can be combined within a single debate depending on the discharge period of the patient. So this is, to my opinion, very important. And once again, just to emphasize on what we require: CT scan, TTE, so the cardiac catheterization with the coronary assessment, because we know, you understand now that coronary disease that is extensive is part of the exclusion criteria. Assessment of the medication of the patient. Make sure that you get an informed consent of the patient, and then you only once you have everything, you send the patient for case review. Let's say it's going to be day 0, day 2, and then you get the green light for randomization. So if you do so, we don't expect a dropout, high level of dropout, but it's going to be based mainly on your screening efficiency. And this is something that we really cannot influence, but if we can help you in any way, come back to us, and we can try to identify some solutions just to make sure that you get all the testings before submitting your patients. So this is quite redundant, but you will get everything clarified. You have it in the booklet, so we're going to go quite fast now. About the anti-thrombotic treatment. This is something that we discussed within the steering committee. It's not mandatory. This is only a recommendation. So you do as you do usually in your daily practice. But if you need a guidance, this is what we said we will try to promote for the Rheia trial. So aspirin should be continued. If the patient is under clopidogrel, for example, after PCI, if it's a BMS, it's not really easy to see. If the patient is randomized in the surgical arm, clopidogrel can be discontinued after 1 month post-BMS or 3 months post-DES. So this is just to provide the guidance. If you want to operate the patient under the combination of aspirin and clopidogrel, you can do so, but this may artificially increase the risk of bleeding. Bleeding is one of the outcomes that is assessed within the trial. So just to make sure that we don't integrate artificial bias that could be prevented by just waiting a couple of months, 1 to 3 months before treating the patients. So if you have to wait, don't consent the patient immediately, because we need 30 days between the consent and the treatment. So wait, and once the patient is not anymore under clopidogrel, you can consent him, consent her, and send the data to the screening committee. So for VKA, in case of atrial fibrillation, what we recommend is to bridge everything to a low molecular weight heparin or unfractionated heparin prior to the implant based on your local practice. We don't recommend to treat the patients under VKA. We do it for TAVI as a routine practice, for example, in Toulouse, but we're going to switch for the trial just to make sure that we all treat the patients more or less in the same way. And then if you have intraprocedural thrombus detection, this is a standard of care and it makes sense. You just have to make sure that you provide additional heparin to the patient and you make sure that you have an ACT that is adequate. And it's up to you to abort the procedure if needed. Okay, this is this is one of the final slides, and it's quite important about the steady device handling. So as I said, we have 4 valve sizes: 23, 26, 3 valve sizes. Sorry, 23, 26, 29. The 23 and 26 are going to be either S3 or S3 Ultra. The 29 is going to remain the S3, the regular S3 as we all know. We won't use the S3 Ultra 29 that is not available for the trial. So what you're going to do is to take the device that you have on the shelf available at your institution. You document the serial number, the kit number of the device you're going to use for the particular patient, implant the valve, and then Edwards will not invoice your hospital for the device that you have used for the patient. So this is something that is quite new. For some countries, Ultra is not available, as for example in France, so we're going to start with the S3, and as soon as the Ultra becomes available, we're going to use the Ultra. So it's going to be a mix of S3 and S3 Ultra based on what you already have at your institution. And you won't get a specific kit for the procedure, but you really need to document the exact serial number. But this is what we do on a regular basis. But this will be provided within the CRF. Okay.